can have this hole here, and it's a very typical place for a hole, any hole in the heart, not just the holes with Tetralogy of Fallot. And 80% of the people that we see who are white would have this type of Tetralogy of Fallot. Now, 20% of those people have some of a defect in what they call the muscular septum, which is a little bit different in that there is more muscle bordering this hole, and this inferior rim is formed by the muscular septum, and the tricuspid valve here and the aortic valve here are actually not related to each other. And that's a little bit different, maybe not so important for the physiology of the Tetralogy of Fallot, but for the surgeon, a very important distinction as he or she goes to close that hole when it goes in for the repair. Well, all these patients have this hypertrophy of the septum, so that of the septoparietal band, so that you have a tight area that closes off the flow to the right, to the pulmonary artery from the right ventricle. Now, Dr. Anderson describes something called a doubly committed ventricular septal defect, and he says it's more commonly found in the Far East, Central, and South America. And this type of defect has still a hole here, but more connection between the aortic and the pulmonary artery right there. So the hole is right under the pulmonary artery. Again, a very important piece of information the surgeon needs, and perhaps Dr. Satzer will be showing us some examples of ventricular septal defects in Tetralogy of Fallot, which is how we help the surgeon plan for the kinds of procedures that he or she will be doing to close the hole. And this is more commonly found in the patients we see in Central and South America and in the Far East. And I've heard described by Dr. Castaneda as saying it's called a Mexican TET when they have this type of VSD. Now, what about Tetralogy of Fallot? What are the things that we worry about, and why are we thinking about having to repair these patients? Well, the patients are blue, and that's because they have right ventricular alpha tract obstruction. It's hard for blood to get to their lungs, so it bypasses the lungs by going through the VSD and going to the body, so the babies are blue. The degree of blueness, or the degree of hypoxia, is related to the degree of tightness as we look out the right ventricle to the pulmonary artery. So it's a very important consideration for intervention for us to think about what is that tight, how tight it is, and where is the tightness. Because we would like to know if we could possibly make the pulmonary valve competent after the repair. The issues that we see in adult congenital heart disease patients are that the valve has been on purpose made insufficient during the surgery, and now we're seeing 20 or 30 years later, those patients are having trouble because their hearts have been exposed to an extra volume, and the hearts are having failure and needing another surgery. So if it's possible to spare the valve and keep the valve in place, that would be an ideal situation for Tetralogy of Fallot repair. So another thing that we think about when we think about intervention, surgical or catheter-based. We also want to know what's the risk the baby has for becoming more cyanotic or hypercyanotic. Patients with Tetralogy of Fallot, we've all seen them, especially when we travel and see the older children who have episodes where they get quite blue and sometimes actually even faint because they don't get enough blood that has oxygen to their body. And that's an important consideration when we think about when to do surgery. The coronary arteries can be abnormal in Tetralogy of Fallot and can complicate the way the surgery is performed. Sometimes the need for a right ventricular to pulmonary artery conduit happens when you have a coronary artery that crosses over the area where the surgeon would normally be opening the subpulmonic narrowing. So those are all important considerations that we think about when we think about how are we going to repair children. And then we also think about children who have non-cardiac disease. There are children who have syndromes, and we need to understand how pulmonary, renal, neurologic outcomes might be affected after surgery based on the type of non-cardiac disease they have. And then determination of when surgery is performed is also often the preference for the surgeon at the site. And that can be a preference for age at time of surgery, or whether or not they prefer to do a palliation versus primary repair, which I'll cover in just a little bit. So what is the timing of preoperative assessment? When are we assessing children for when they need to have surgery? Well, the answer is all the time. There really isn't a one time where we say, oh, now we have to think about surgery in a Tetralogy of Fallot patient, because the Tetralogy of Fallot patients have a dynamic obstruction to their blood flow and are constantly changing. Our assessment often begins in fetal life, with many of our patients being diagnosed in the fetal fetal scan, which is in the second trimester. And we're trying to decide, is that baby going to be okay at birth, or is that baby going to be too blue and going to need to have prostaglandins to open the PDA? At the neonatal first time assessment of the Tetralogy of Fallot, we spend a lot of time looking at the level of right ventricular tract obstruction and degree of obstruction, again, trying to predict when that baby is going to become more cyanotic and need to have surgery. And then we have ongoing assessments, always looking at that level of obstruction and the degree of obstruction, so we have a better understanding about whether or not that child is going to be at risk for more cyanosis than we would like to see. We would like to refer babies kind of just right before they're going to have that trouble, because it's nicer when they're a little larger to do the surgery. So what do we assess when we think about these patients with Tetralogy of Fallot? Like all medical providers, the first thing we assess is the clinical presentation. How are those babies doing? The degree of hypoxia, again, is dependent on the degree of outflow tract obstruction, so that if a baby does not have a lot of outflow tract obstruction, they can actually more look like a VSD in those babies you see with heart failure in the left to right shunt. Some children with Tetralogy of Fallot have a balanced circulation. The pulmonary stenosis is just enough to prevent a large left to right shunt, but not too much to cause a big right to left shunt. So they're actually pink without any heart failure. Children with Tetralogy of Fallot are most commonly cyanotics. They do have some decreased saturation, but not enough to be concerning for quite a period of time over the first few months of life. But some children are very cyanotic when they're born and then need an intervention right almost immediately after birth. And then children have hypercyanotic spells. We just had a baby admitted to the Children's Hospital, 10-month-old, who was having a hypercyanotic spell despite being a fairly well-balanced patient. So that is driving us to say that patient needs surgery. And the clinical presentation can range from porphyria and tachypnea, which we would see in a patient who's like a VSD, to cyanosis and irritability in a patient who doesn't have enough oxygen. And we're also looking at the oxygen saturation and the hemoglobin, which we always do when we see those babies. Every time we see them, we certainly do oxygen saturation, and hemoglobin is a sign of how often they are hypoxic, because the hemoglobin will rise as the patients don't have enough oxygen delivered in their normal fashion. This is an interesting paper. It's a very old paper, 1964 to 1972, following a group of 59 children with Tetralogy of Fallot. This was before we had SAP monitors, but how they looked. And if you looked at them with Tetralogy of Fallot diagnosed, over 68% of them were not cyanotic at birth. This shows that over time, 5 months and 9 months later, that the number of patients who were not cyanotic drastically dropped, showing that Tetralogy of Fallot is a dynamic process with increasing hypoxia as the children age. So we know that in the first year of life, we're following them fairly often, every month to 2 months, to see what's happening to their oxygen saturation as they grow and their pulmonary stenosis sometimes gets more severe. So I'm going to introduce Mike Satzer, who's here, and he's going to show you some of the echo images and think about how the echo attendings look at the assessment of the patients with Tetralogy of Fallot. So I'm going to stop sharing my screen. You should all see each other for a bit, and that's Mike Satzer there. Wave a little bit, Mike, just say hello. And Mike's going to start sharing his screen, show you some echoes. So we can see your screen, Mike. We're good. We can't hear you, though. Still can't hear you. So it's like Betsy, right? Betsy, maybe you should help Mike.
The way I did it was turning on my volume in my computer.
Michael, scroll your mouse down to the left bottom corner of your screen, and there's a mute, unmute.
Yeah, maybe your screen's not letting you share the microphone, Mike, you know? Your computer.
Can you hear me now?
Yeah.
Absolutely, yes.
Okay. Sorry about that. And you can see my screen too, right?
Yep.
Okay, great. Let me just move over. Okay, so thank you, Daphne, and thank you to Heart Care International for inviting us to speak today. So I'll review the basic assessment of tetralogy of Fallot by echo, and I'll begin by briefly reviewing the use of fetal echo to predict the need for neonatal surgery, or in other words, postnatal dependence on a patent ductus arteriosus. So based on published literature, there are a few features derived from fetal echo in predicting ductal dependence. And I'll briefly go through this list here. I should note that there are several published normal values for fetal cardiac structures, and most commonly utilized in the publications on tetralogy of Fallot is that of Schneider et al. From Ultrasound in Obstetrics and Gynecology. And this and other z-scores can be calculated online, such as at the website listed below. So the most useful prognostic indicators on fetal echo are the direction of flow across the ductus arteriosus and the pulmonary valve diameter z-score. Several publications have shown that abnormal left to right flow is associated with a very high likelihood of ductal dependence. Those who have bidirectional flow seem to be somewhat split. So one publication from Columbia Medical Center showed between 50 to 60% to be ductal dependent, whereas only 1 of 21 cases with all right to left flow, which is normal in fetal life, were ductal dependent. And so to summarize, all left to right ductal flow seems to be highly, show a high positive predictive value for this outcome of needing a ductus arteriosus postnatally. Smaller pulmonary valve diameter z-scores also correlate with ductal dependence. And a z-score below -3 to -3.5 have been associated with greater incidence of ductal dependence, with the highest amount below z-score of -5. The next markers, which are a z-score of the main pulmonary artery and the ratio of pulmonary valve to aortic valve diameters, were significantly different between ductal dependent and non-ductal dependent patients. But unfortunately, there's probably no useful cutoff. So these metrics are really only useful when paired with the other findings that we're looking at. The pulmonary artery cross-section ratio, which is the ratio of area of the main pulmonary artery to the branch pulmonary arteries, was examined by a group in Japan and found to be predictive of ductal dependence in a small cohort when this ratio is less than 0.6. However, the authors also noted that all patients had left to right flow across the ductus arteriosus, so probably this latter is still a better marker of ductal dependence. Of note, the rate of growth of the pulmonary valve during gestation is not predictive of ductal dependence. All patients seem to have an increasing absolute value as well as increasing z-score over time in tetralogy. Interestingly, the ductus arteriosus is completely absent in about 9 to 29% of cases of tetralogy, but this is not predictive of a worse postnatal outcome. This is an image from one of our recent fetal cases. This patient had bidirectional flow across the ductus arteriosus, and just to give you some orientation, anterior is up, posterior down, and the fetal head is towards the left. So this is flow from the aortic arch across the ductus arteriosus to the PAs. And if you move to a Doppler, PW Doppler interrogation, this confirms that there's bidirectional flow across this duct. This specific patient did require neonatal intervention within the first month of life. This is another patient. This is a 3-vessel view showing the SVC. I think I need to turn on my laser here. It's showing the SVC, aorta, and branch pulmonary arteries. And this is an excellent location in which to measure the branch pulmonary arteries as well as the pulmonary valve. Moving on to postnatal evaluation by a transthoracic echo, I'll review the most important features that should be assessed prior to surgery. These include imaging of the right ventricular outflow tract and pulmonary infundibulum, the pulmonary valve, the main and the branch pulmonary arteries. Tetralogy can be associated with a number of arterial and venous abnormalities as well, the most common of which is a right aortic arch, which is seen in up to about 25% of cases. Identifying these and other findings may indicate additional surgical intervention or alert the surgeon to obstacles that would otherwise complicate the repair. Other abnormalities may include vascular rings, such as double aortic arch, and abnormalities of the pulmonary artery, such as origin of the LPA from the RPA, or otherwise known as LPA sling, or discontinuous pulmonary arteries, such as arising from a ductus arteriosus, or other location of the systemic arterial system. Venous abnormalities, which occur not uncommonly in tetralogy, may include abnormal course of the of the innominate veins, such as a retroaortic innominate vein, or persistent left superior vena cava draining to the coronary sinus. Coronary abnormalities may also be seen in the presence of major coronary artery branches that cross the right ventricular outflow tract can be observed in about 5% of patients with tetralogy. And this may dramatically affect the surgical repair. Such a finding would likely prohibit the use of a transannular patch and may require instead the use of a right ventricular to pulmonary artery conduit. I have a few examples of coronary abnormalities from patients we have seen. Of note, the right aortic arch, vascular rings, and deficient thymus are all associated with 22q11 deletion syndrome or DeGeorge syndrome. For the sake of time, I'll skip some of the more rare associations that can be seen in tetralogy. One of the most useful views in these patients is the subxiphoid right anterior oblique view, or RAO view. This is obtained by rotating the transducer about 45 degrees counterclockwise or anticlockwise from the subxiphoid long axis view to about 1 or 2 o'clock, the notches at 1 or 2 o'clock. This permits ideal visualization of the right ventricular outflow tract. The right ventricular inflow and pulmonary infundibulum can be seen clearly in this view. Color flow can also help identify location of subvalvular pulmonary stenosis. The following 3 clips are from 3 separate patients with tetralogy with varying degrees of infundibular obstruction. And just to orient you, the tricuspid valve is on the lower left, adjacent to the right ventricular inflow. And this is the right ventricular outflow or infundibulum. The anterior malalignment of the conal septum and hypertrophy of this septum can be seen clearly here. The left ventricular outflow tract and aortic valve are seen above the defect in this view. This first patient has normal saturations, or had normal saturations, and on echo had normal pulmonary valve and pulmonary artery measurements. The second patient had more significant hypoplasia of the right ventricular outflow, although also had normal oxygen saturations. And he eventually went on to have a routine surgical repair at about 6 months of age. So again, more hypoplastic pulmonary infundibulum. Although this next image could probably be optimized a little bit better, in this third patient, I think you can appreciate the infundibulum is even more hypoplastic. The baseline saturations in this patient was about 90%. And this patient required neonatal intervention for unusual early hypercyanotic episodes within the first few weeks. It's important to note, like Daphne stated earlier, that the right ventricle can become more hypertrophied with time. In this first patient, after 3 months, the base of the infundibulum became more hypertrophied. And this required intervention around this time, around 3 months of age, due to the development of hypercyanotic spells. This is the same patient with color mapping that shows flow acceleration at the base of the infundibulum. Subcostal views are also permit the best visualization of an atrial septal defect. Although the surgeon may intentionally leave a small atrial communication after surgery, larger defects are generally closed at the time of repair. The 4-chamber apical view allows inspection of the atrioventricular valves and ventricular function. The size of the tricuspid valve is surgically relevant, as intervention on the right ventricular septal defect and infundibulum are made through this valve via right atriotomy. One surgeon with whom I've worked prefers the tricuspid valve to be greater than about 1.5 centimeters for this reason. Although not shown, color sweeps of the ventricular septum and apical and short axis views should be performed on a low scale or low Nyquist setting in order to identify additional ventricular septal defects that might be present. As the right and left ventricular pressures are nearly equal in unrepaired tetralogy, even significant muscular VSDs can sometimes be overlooked. Parasternal long axis views allow demonstration of aortic override, seen here. This is the right ventricle and the left ventricle. which is due to anterior and cephalad deviation of the conal septum, as Daphne mentioned. This helps to differentiate tetralogy of flow from, for example, double chamber right ventricle. And this latter is more associated with isolated membranous defects and a normal appearance of the infundibulum. This view is also useful in identifying a dilated coronary sinus, which is commonly due to drainage of a persistent left superior vena cava to the structure. And this is seen in up to about 11% of cases of tetralogy. And this can also be confirmed later in suprasternal imaging. The sweeping anteriorly from the parasternal long axis view permits a visualization of the infundibulum and pulmonary valve. In many cases, the pulmonary valve may be thickened or doming in appearance, and that can be seen in this view. Rotating 90 degrees gives us the parasternal short axis view, again demonstrating the large ventricular septal defect and hypertrophied conus and narrowed infundibulum. I don't have images of it, but as Daphne mentioned, you can have hypoplasia of the infundibulum, also known as a Mexican TET. And this may be associated still with pulmonary valve stenosis or more VSD physiology as well, but you will see absence or hypoplasia of the conal septum in such views. This is also the view where the pulmonary valve and main pulmonary artery are typically measured. It also allows Doppler interrogation of the right ventricular outflow. And you may be familiar with this Doppler pattern termed double envelope, in which there are two levels of obstruction leading to overlaying Doppler spectra. In this case, the dagger-shaped envelope indicates dynamic right ventricular outflow tract obstruction, which increases during systole as the infundibulum narrows. In general, the gradient across the right ventricular outflow tract does not necessarily indicate need for surgical intervention. Clinical factors are much more important in this regard, but a low gradient, for example, may indicate a patient with minimal outflow tract obstruction and more likely to have VSD type physiology. The branch pulmonary arteries are not, if the branch pulmonary arteries are not well visualized in this view, the transducer may be moved higher on the chest and angled slightly inferiorly, as seen in this view. And this allows measurement of the branch pulmonary arteries, which are typically made near the point of bifurcation. This also allows visualization of any pulmonary artery abnormalities, such as pulmonary artery coarctation or discontinuous pulmonary arteries. In our lab, we use the Boston Children's Hospital Z-score calculator, which can be found at the website below. A pulmonary valve Z-score significantly smaller than a -2 indicates an increased likelihood of requiring a transannular patch. In this next image, assesses the aortic arch branching from a suprasternal view. In this first patient, the first artery or first branch of the aorta bifurcates and then heads leftward. And that shows that this patient has a right aortic arch. In the same view, angled a little bit more inferiorly, this patient can be seen also has a retroaortic innominate vein that courses inferior to the aortic arch. This can also be seen from a sagittal window where the innominate vein is seen adjacent to the right pulmonary artery instead of anterior and superior to the aortic arch. And lastly, I'll show a couple examples of coronary artery abnormalities. Again, approximately 5% of patients with tetralogy will have major coronary arteries or a major coronary artery crossing the right ventricular outflow tract. Parasternal short axis view of this patient shows the origin of the left anterior descending coronary artery from the right coronary artery. One thing I should mention also is that often the aortic root is rotated clockwise in this echo projection, so that the the aortic commissures are rotated clockwise, and the origins of the coronary arteries may also be rotated clockwise. In the same patient, only the circumflex artery originated from the left aortic sinus. This was confirmed on cardiac catheterization. In these images, the left anterior descending can be seen to fill after injection of the right coronary artery. This patient required eventual placement of a right ventricle to pulmonary artery conduit, although the native right ventricular outflow tract was preserved. Later angiography with root injection in this patient shows the course of this coronary between the stented conduit and the native RVOT. This next patient has normal coronary artery origins, but a prominent coronal branch from the right coronary artery that crosses the right ventricular outflow tract. Again, this may affect the method of surgical intervention and prevent use of a transannular patch. Finally, although this last patient has no coronal branch, the right coronary coursed leftward over the outflow tract before then heading rightward. And this patient had a normal left anterior descending. However, on surgical inspection, the right and left coronary arteries were within 3 millimeters of each other over this narrowed right ventricular infundibulum. This led the surgeon in this case to defer complete repair in this child who was only 2 weeks of age. And instead, so this is the left coronary, right coronary, and this is a very small access to the right ventricular outflow tract. And instead, in this patient, a modified BT shunt was placed between the right subclavian and the right pulmonary artery. And this was done to supplement pulmonary blood flow and allow the child to grow and eventually undergo later a comprehensive repair. Thank you again, and I'll return the presentation back to Daphne.
Thank you, Mike. Let me get back to my presentation. So as Mike showed you, the echocardiogram is really the cornerstone of the way that we evaluate tetralogy of Fallot. And in the vast majority of cases, it is sufficient to tell you all the information that you need to make decisions about surgical intervention, and no further imaging is needed. But in some cases, particularly looking at the coronary arteries, there is a need to look for advanced imaging, and we call that MRI or CT. The problem with MRI or cardiac MRI is, as we know, it is a long procedure. It can be kind of upsetting to children because of the noise it makes. It requires sedation. And the one thing that we avoid as much as we possibly can in tetralogy of Fallot patients is giving sedation in an uncontrolled situation, because that can cause a hypercyanotic spell. So cardiac MRI is used very sparingly in children with tetralogy of Fallot. Cardiac CT is a little more appealing because it can be performed limited or no sedation in some children. Some babies you can't, because they just can't sit still for the brief CT images. But I think would say between the two, cardiac CT is preferable. And cardiac CT really is used to look at coronary artery anatomy that might not be clear from the echocardiogram. Evaluation of the right ventricular outflow tract, including the distal pulmonary arteries, which is sometimes difficult to see on echocardiogram, and to look for the presence of aortic pulmonary collaterals or discontinuous pulmonary arteries if they can't be well seen on echocardiogram. This is a nice study by Gu in Korea, where the performance of cardiac CT for tetralogy of Fallot was standard in their population. So they had a nice way to look at the incidence of coronary artery anomalies. They looked at a group of 318 children who underwent cardiac CT before tetralogy of Fallot surgery, and they found that 5%, like Mike had said, 5% of patients had a surgically critical anomaly of their coronary arteries that affected the way the surgeon approached the tetralogy of Fallot repair. And the combination is similar to what the pictures Mike showed you: a prominent caudal branch crossing the right ventricular outflow tract, the right coronary artery arising from the left sinus, an accessory left anterior descending artery, the right coronary from the left anterior descending artery is shown in this picture. And basically the issue with these coronaries is that this is the pulmonary artery. The surgeon needs to open this area up in order to relieve the stenosis. And if a coronary artery is traversing it, then you cannot open it up without interfering with the function of the coronary artery. And a conduit has to be considered. The reason a conduit is an important thing about a conduit is that the conduit is a given size in a child, so that we like to avoid putting conduits in small babies because we know that they will by nature become stenotic as the child grows. And left coronary artery from right coronary artery is another anomaly that is seen, and atresia of the right coronary artery. So there's a wide variation of different coronary artery anomalies that might be considered a critical finding that would affect the type of cardiac surgery that's performed. Now, what's the role of cardiac catheterization? Now, diagnostic cardiac catheterization is actually very rarely performed in Tetralogy of Fallot because of the availability of echocardiogram and advanced imaging. There's this nation risk with cardiac catheterization, so most often we're doing this in settings where we are planning an intervention. But it can be used when advanced imaging is not diagnostic to look at aortopulmonary collaterals, anomalous pulmonary venous drainage, other associated lesions with tetralogy that cannot be well distinguished on either echo, CT, or MRI. Now let's move to just thinking about surgical approaches. And we have some surgeons on the phone, so I certainly wouldn't want to speak for them. So I'm going to give you my cardiology view of the surgical approaches for Tetralogy of Fallot. So Tetralogy of Fallot, basically the problem is the patients do not have enough oxygen. They're cyanotic. They can have a palliative procedure. The earliest palliative procedure was the Blalock-Taussig shunt, which we all know the great story of Dr. Blalock, Dr. Thomas, and Mr. Thomas and Dr. Taussig. And this is a very effective early palliation to improve pulmonary blood flow. It was traditionally done as an aortopulmonary shunt, but now balloon dilation of the right ventricular outflow tract, right ventricular outflow tract stent, and PDA stent are all procedures described to improve pulmonary blood flow without a repair of Tetralogy of Fallot. A repair of Tetralogy of Fallot, if possible, valve sparing, may require a transannular patch or an RV-to-PA conduit. Really addressing the RV outflow tract obstruction and closing the VSD are the two major components of the surgical repair of Tetralogy of Fallot. Now, survival after Tetralogy of Fallot has improved tremendously since 1975. And even from 1958 to 1975, when it was first born, there were vast improvements. But in 1975, early survival after Tetralogy of Fallot repair is 70%. With a 62% survival 15 years after repair. In the current era, not even current, meaning 1990 to 2018, so a nice 20-year period, 98% of children do well after surgery in the immediate postoperative period, and 95% are surviving at 15 years. So this is looking, you could see how the evolution of using palliative procedures to palliate Tetralogy of Fallot has become less and less common as the survival after repair of Tetralogy of Fallot has improved so well that patients can undergo primary repair. So how do we think about palliation versus repair in Tetralogy of Fallot patients? Well, pretty much I think all surgeons would advocate to do a primary repair in children who are over 3 months of age with Tetralogy of Fallot. You'll see quotes that surgery is ideally performed between 3 and 6 months, 6 and 8 months. Basically, sometimes somewhere between 3 and 8 months is when surgeons feel very comfortable doing elective Tetralogy of Fallot repair. Not a lot driving that, meaning not a lot of cyanosis or not severe cyanosis, hypercyanotic spells, just the presence of a Tetralogy of Fallot, because it is not a lesion that's going to fix itself. Now, what are the considerations for not doing a primary repair? Well, that would be the need for right ventricular pulmonary artery conduit, as we saw with coronary artery anomalies, whether or not there's some discontinuity of the pulmonary arteries or major aortopulmonary collaterals. Those patients might first undergo a unifocalization to bring those pulmonary arteries together before undergoing a primary repair. And then children who have associated complex lesions or non-cardiac lesions that make surgery not a good option, primary surgery not a good option. Perhaps they have a concomitant infection, a lung infection, but are cyanotic. You might not want to do a primary repair, but might go with one of the palliative procedures that we listed in the slide before us. Now, children less than 3 months of age is still a little bit of a controversy, and the pros for palliation would be that the procedure does not require cardiopulmonary bypass in a small infant or neonate. Some papers say it promotes better PA growth, where others say it impairs PA growth. And there's less need for an transannular patch that's been described in children who first go on palliation and primary repair. But the benefits of primary repair are that there may be better pulmonary artery growth because it's more physiologic circulation. It's single intervention. The children are not exposed to a second run of anesthesia and of surgery. So there is still, I think, a lot of choice between centers about who gets palliated and who undergoes a primary repair. Not a lot of evidence to say what is the best course to take, although this was an interesting paper from Dr. Gian and published this year in JTCVS that showed that looking at the pulmonary valve annulus Z-score and outcomes, this is outcomes in the early, basically the first year after Tetralogy of Fallot repair, sort of favored a stage repair in patients who had a very small pulmonary valve annulus and a primary repair in those who had a Z-score that was in the normal range. This shows that the improvement or the idea of having an optimal early outcome really in a primary repair really improved quite a lot if the pulmonary artery Z-score was between above -3, and stage repair could be considered. So this was sort of an argument to say there was still a role for stage repair in a small neonate who needs surgery because of hypercyanosis. If you think about how you would do the palliation, BT shunt is the classic long-standing mode of palliating a tetralogy of Fallot because it provides blood flow to the lungs through a connection from the subclavian artery, aorta, to the pulmonary artery. And versus stenting, the right ventricular alpha tract, which relieves the obstruction by opening up that area of infundibulous stenosis. This is a nice study from Dr. Quant. They had 100 patients. These are not randomized, but they just compared their 100 patients, 60 of whom had a right ventricular alpha tract stent for cyanosis and 41 who underwent a BT shunt, just to see what their outcomes looked like. Now, if you looked at the patients who had a right ventricular alpha tract stent, they had been more patients underwent that procedure than the BT shunt. 60% of them underwent complete repair. 8% of them died after the procedure. Some of them were still palliated, and some of them crossed over because the stent didn't work and they had to go to a BT shunt and underwent complete repair. If you looked at the BT shunt group, complete repair was achieved in 95% and only 5% death. But this is, of course, small series, and their conclusion from their data was that a right ventricular alpha tract stent, while it does cause the patients to undergo their tetralogy repair earlier, this is age, this is months post palliation, this is patients who had a BT shunt and patients who had a RBOT stent. They underwent the surgery for tetralogy repair earlier in this case, but they did not have any change in mortality. So their argument was avoid a cardiopulmonary bypass run. The stent is a good option when it can be done. Obviously, since it wasn't randomized, you have to know why did they do the stent versus why did they do the BT shunt. But it certainly is an option that should be considered in patients in whom you think you might be able to get away with it and be ready to do a surgery at 6 months of age. Now, this is from the same paper that showed all the coronary anomalies, just to show you a little bit about what they saw in those 320 patients as a consecutive series, what kinds of surgeries were done. The majority of patients were able to have surgery, 68%, with a non-transannular patch, meaning they were not left with a lot of pulmonary insufficiency after the surgery, but they did the surgery through the right ventriculotomy. So a little bit of an old style that we don't do anymore. Transaxial, transpulmonary approaches are more common in the current era of tetralogy of Fallot repair, and 24% needed a transannular patch. 30% of the patients needed something done to the branch pulmonary arteries, which is why it's important on imaging that we establish what the pulmonary arteries look like and if they need any intervention while the surgeon is in the chest, so that we don't have to go back and do any procedures in the early postoperative period to relieve a stenosis of the right or left pulmonary arteries. So that is the end of our presentation. I would say some take-home messages are that the need for intervention is driven by the degree of RV alpha tract obstruction and cyanosis. Non-invasive imaging is the mainstay of anatomic evaluation prior to intervention. The risk-benefit of palliation versus primary repair really depends on the size of the pulmonary valve, the level of the alpha tract obstruction, and surgeon preference. So thank you for listening, and I'm happy, and I see a lot of people on the call who would be very very qualified to discuss how they think about surgical and preoperative assessment of tetralogy of Fallot.
Wonderful, Daphne and Michael. Thank you. Thank you very, very much. You know, Daphne, we have quite a strong audience for this wonderful global pediatric cardiology grand rounds. And I know that we have colleagues in Central and South America. Perhaps if some of them have any specific questions, we should start with them and then turn our attention towards comments from other team members, even our surgeons. But let's see if we have any comments from our colleagues in Central and South America. Please unmute yourselves too. Hearing none, do we have comments from some of our other colleagues?
All right, I'm going to go first. Daphne, Mike, thanks for a great presentation. My question is as to what your philosophy is in terms of following up these patients, because one issue that I find a little difficult is how do I counsel parents about whether or not this kid's going to have a TET spell? How frequently should I monitor them as outpatients? Should I cave in and tell them it's okay to buy a SAT monitor because you know that they're going to be on the phone 5 times a day saying that the saturation is 83%? How do you approach that issue?
Yeah, that's a great question, Raj. I was just looking, I was trying to find some papers about what predicts a TET spell. I couldn't find any. Okay, so it is difficult. What's my impression? My impression is that this is an infundibular subpulmonic problem. So the echo is important because you're looking at the subpulmonic. If you think about dynamic obstruction, that is usually going to be in the muscle of the right ventricle. So as I see that on my follow-up echoes start to hypertrophy, I get more concerned that those patients are going to be at risk for hypersonic cells. And of course, classically, we always say the pink TET spell. The blue TETs are blue. They tell you they have to go to surgery just because they're blue. So they've already given you your little sign because their saturations are falling and just gradually going down from 85 to 80 to 75. But the pink TETs are the ones who can have exactly the one we have in the hospital, 100%, and all of a sudden goes down to 70 for no reason. And so I think that age, the subpulmonic area, the idea that it usually doesn't happen in the first couple months of the blue patients. They just get bluer. It's a little unusual. I know Mike showed us that one patient that did it, but thinking as more of an awareness as they get to be 4 to 6 months old, which is why I think it's a good idea when you think about surgery, you do it. And yet we have a lot of colleagues on the line who see patients who are 2 or 3 years old and they've made it through, and they're not spelling, they're doing their squatting and managing their own cyanosis. I'll just be curious if anybody is seeing the Mexican type of, does it seem more common amongst the people who care for the children down in the South America, Central America region? If anybody's on the phone.
I may ask a question of the surgeons on the call if I can. This is Peter Dyke from University of Missouri. First, let me say, Dr. Sue and Dr. Satzer, I thought that was an excellent, one of the most detailed and concise presentations that I've heard. I really enjoyed it. Regarding staged repair, whether it's an RVOT stent or a VT shunt, when you return for the second procedure, do our surgeons or any of the surgeons on the call have concerns or preferences for one versus the other? Does one approach make the final repair, or I should say the more complete palliation, technically more or less challenging?
I've not known Alistair or Ibrahim to be bashful. Gentlemen.
Sure. Hi. This is Ibrahim. Very, very nice talk. Daphne and Michael, it was very, very comprehensive talk and touched very well on the surgical aspects as well. Peter, your question about stent versus BT shunt, my own preference would be to have no stent in the RV outflow tract if possible. However, I think the usage of a stent versus a BT shunt is quite institutional dependent, and if a stent is in the RV outflow tract, and most likely that patient will likely require a transannular patch, and there's a question about whether to remove that stent in the process or cut through it, depending on how embedded it is a question that becomes more relevant in the operating room. But again, as far as the BT shunt goes, you sometimes have to be mindful of the impact of the BT shunt on the RPA, especially if it's a right modified BT shunt as opposed to a central shunt, and you may have to do some augmentation or plasty of the RPA in the process of your complete repair as well. So, but my preference would be to, barring any institutional desire, it would be to deal with a situation where there was no stent.
We should really have some wine and crackers or something. Everybody's a little like Saturday evening.
Other questions?
Actually, the only other thing about the BT shunt is if you do it through a sternotomy versus a thoracotomy and the need for redo sternotomy. The one benefit is if you have a small pulmonary valve, is doing a stent allows it to be cored out like an apple core, and knowing that you're going to get rid of the pulmonary valve. So if the pulmonary valve is small, a stent can be very good because it's easy to do, knowing that you're going to do a transannular patch.
I'll ask another question if everyone's going to be shy. I like this group and I like to hear what you had to say. I always learn something. So a question maybe for the cardiologist. Do you all use beta blockers? And if so, how do you choose which patient gets a beta blocker and who doesn't? I will say I very rarely put my patients on a beta blocker. My approach has been, if I'm concerned about cyanosis, I push them a little more aggressively to my friendly neighborhood surgeons and try to avoid, but maybe that's not the right thing to do. What do you do?
So I think I'll take the bait, though this might take another hour to discuss and we'll still not arrive at a consensus. I think it's pretty institution specific. When I was at Einstein, Montefiore, never used propranolol. And now at Sinai, there's a huge bunch out here that believes in propranolol. So I'm not so convinced that it is efficacious. And I think if the kid's cyanotic, he or she is telling you something, and it's usually not a demand for propranolol. It's a demand for a knife. So I personally don't think it's efficacious, but my colleagues use it and they seem to like using it.
I mean, when we did not do early Tetralogy of Fallot repairs, because I'm old enough, and Mom's old enough to know that we didn't do repairs sometimes before 9, 10, 12 months of age because of the technical issues. When we used propranolol. Almost every child got propranolol because it does slow the heart rate. We use esmolol to treat a TET spell. I think now that we're pushing, to repair at 3 months, it's why would you use propranolol? Send them to surgery. So it really kind of depends on the surgical availability. So I wouldn't say propranolol is wrong. I would just say, depending on when your optimal timing for repair is, if it's going to be past 6 months, then I wouldn't be adverse to using propranolol in that situation to get the patients older, hopefully, without having their hypercyanotic spells. Any other questions from people?
I'm going to read out Ken Remy's question. Does anyone in pediatrics like using beta blockers that weren't invented in the 1960s and have more cardiac selectivity? No. I think the advantage of propranolol is it's that it can be given. First of all, we have a lot of experience with it for rhythm issues. I like the fact that when I have to use it, it can be given 3 times a day. And I don't think atenolol is available as a liquid. So no experience with anything other than propranolol. And that too is pretty sparing.
Yeah, I think it's because we're giving it to the kids less than a year, Ken. So there isn't much available. I don't think there's not a liquid atenolol. I don't know about a liquid metoprolol.
Yeah, I was thinking more like metoprolol or some of the newer beta blockers, not necessarily atenolol or propranolol.
Yeah, I just don't think they come in liquids.
That might be true.
Do they?
Not to my knowledge. Though, of course, Anexia will compound almost anything for you.
Yeah, I know. But for propranolol, it's nice to have something relatively safe that you use.
Yeah, I've used both atenolol and metoprolol in compound form thanks to pharmacy, but we just have so much experience with propranolol, and it's a bit shorter acting. So in the babies, that maybe that's just, it makes me feel better knowing it's not going to stick around as long if we get into trouble.
That makes sense.
How often these days are you encountering cyanotic spells that are difficult to resolve and require emergent surgery? And if they require emergent surgery, how often are those requiring cardiopulmonary bypass just to stabilize the child to put in a shunt? So 2-part question. Anybody?
We had 2 in the past year. Who surprised us? The small babies, and they were very sick. And they needed to go on bypass to stabilize them before they could have their surgeries. And I think one patient got a shunt, was the patient Mike showed with the coronaries so close to each other that the surgeon just said, I'm just going to shunt the patient. And the other one, I think, got a repair. So it still happens. Not very often, hopefully. And maybe we'd had a little self-examination to see how we should follow these patients a little more closely. Because it's a bad situation. Once they start to spell, you don't have a lot of options.
So I asked this question primarily as sort of a thought experiment for our colleagues in Central and South America who may find themselves limited with options, and not to be bashful about taking a patient to the operating room and actually putting them on bypass. Circumstances may be such that that's your only option, and I think what you're saying is don't hesitate doing so under such circumstances. Would that be good advice for us to give our colleagues?
Yes.
Perhaps,
Right.
I was going to say perhaps analogous, and I think an issue you're pointing to, which is a great point. So I practice 100 miles from my closest surgeon, and I alter the care with that in mind, which is one reason why I asked about shunt versus RVOT stent. In the last 10 years, I've had no patients present to my hospital with a TET spell requiring a surgical bailout, but I have had a BT shunt with an acute thrombosis. And I don't have, again, my interventional capabilities are 100 miles away, so it's a big problem. So I tend to push my patients. I try to look at all the data that Dr. Satzer and Dr. Su presented regarding likelihood of ductal dependence, and maybe undoubtedly push some of my patients to complete repair earlier. And maybe that's more analogous to our colleagues in Central and South America who may not have ready access to surgery, at least not that you all in New York do. I'm jealous of you in New York.
I think that's Peter. I think that's a very, very interesting point you bring up regarding, and also Rob, regarding cardiopulmonary bypass, and particularly shunts. So, even if a kid were, say, intermittently spelling but stabilized, and you're taking that patient to the operating room for, say, a shunt, I don't think that one can totally dismiss the need for cardiopulmonary bypass. One of the first things that we'll do is we'll clamp the RPA as a test occlusion and see what the saturations and hemodynamics are in the operating room. And if they're not favorable, then the patient would require cardiopulmonary bypass for that BT shunt, which would then tend to tip the scale for the surgeons in the current era, or at least some of them, I think, to consider a complete repair at that point in time as well. Because if you're going to utilize cardiopulmonary bypass, then perhaps this might be the time to just do the complete repair. But of course, the child, the whole clinical picture has to be in mind as one goes forward with that. But I agree with you, Peter. I think my own practice has been to try to do early primary repairs whenever the child were to present. So if the child were to present with a spell, to consider that. However, again, it depends on the institution and comfort level and the post-operative management. But I could see a beautiful role for, an RV outflow tract stent. There you don't have any, you have no sternotomy, and you can get, bail the child out in, in the cath lab potentially, and then deal with it down the road. So, but yeah,
So one thing people have to remember, though, is neurodevelopmental outcomes are diminished in patients and increased risk of attention deficit disorder when you put kids on bypass less than 6 months of age. So palliative procedures. And then when you look at the STS data, mortality rates for early repairs, either palliative or TET repairs across the board, are 8%. And when you can get them to six months of age, it's less than 1%.
Yep. Point well taken. Yep.
Well, this has been wonderful, and I know we're beyond our hour limit. It's kind of hard to say goodbye seeing so many wonderful faces and names on the call. We will be doing this on a regular basis. Heart Care International is committed to an educational program, especially now during COVID. And we want to stay in touch with each other, but we also want to stay in contact with our colleagues throughout Central and South America with whom we've been working for years. So this is for all of us. I will share with you that we will have another call coming up. Margaret, if you could unmute yourself and share with everybody the date of that call. And I think that Ken and Alistair are going to be hosting that one. And we will be doing additional calls like this and pediatric cardiology ground rounds throughout 2021. So Margaret, if you could just tell everybody when that next meeting will be.
Yes, the specific date has not been confirmed. We're looking at the week of December 14th. Everyone who got the invitation to this webinar will get that invitation as well. Alistair and Ken, did you want to talk anything about the topic of discussion for that?
I think it's timely for us to talk about COVID, and I think there's a nice opportunity to where we could talk about having some different experts that have COVID expertise, as well as the impact upon MISC and in the cardiac conduction system, as well as acute heart failure.
That's tremendous. And we also will welcome your advice on additional educational conferences. So please email the Heart Care International office and Margaret and let us know which topics might be relevant for you and helpful for all of you. With that, I want to say once again to Michael and to Daphne, thank you, thank you, thank you. Wonderful talks, very, very helpful, very clear, and certainly extremely valuable for all of us. So thank you both, and best wishes, all of you. Stay healthy, stay safe, and have a wonderful holidays. And we'll hopefully talk and see you before the